Welcome to the Jaspal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome back returning guest Scott Halpern, who is a pulmonary critical care physician and newly minted palliative medicine physician and researcher and director of the PAIR Center at the University of Pennsylvania. PAIR stands for Palliative and Advanced Illness Research Center. Scott, welcome back to the Jaspal Podcast.
Always great to be with you guys.
And we're delighted to welcome back Kate Courtright, who is also a pulmonary critical care and palliative care physician and researcher and core faculty at the PAIR Center at the University of Pennsylvania. Kate, welcome back to Jaspal.
Thank you for having me again.
And we're delighted to welcome Jaspal Singh, who is a pulmonary critical care and sleep medicine physician who practices at Atrium Health and the Wake Forest University School of Medicine. Jaspal, welcome to the Jaspal Podcast.
Very happy to be here. Thank you for having me.
So we got a good topic today. We're going to be talking about a JAMA IM paper that just came out not too long ago on nudging clinicians to promote serious illness communication for critically ill patients. We've done a podcast already on nudging. What was the nudging podcast?
We've done, I feel like a couple.
We had Scott and Kate talk about a nudge on default palliative care. We also had a podcast.
We had one with Jenny Blumenthal Barbie and Scott about what are nudges in general.
And we'll talk a little bit about that. I encourage you guys to listen to both of those. We'll have links to that in our podcast notes. But before we dive into this topic, is it Jaspal, do you have a song request for Alex?
Well, I thought we requested Imagine by John Lennon.
Why did you choose Imagine by John Lennon?
Well, it's such a nice song about compassion, kindness, and the idea of us thinking of a world where the right things happen consistently all the time, and that's the culture, and which is what we're trying to accomplish with these types of nudges.
Great.
I love it. And we could all use a little John Lennon Imagine right now. Here's a bit. Imagine there's no countries. It isn't hard to do. Nothing to kill or die for. And no religion too. Imagine all the people living life in peace. You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us and the world will be as one.
Thank you, Alex.
Thank you for that choice, Jaspal. Needed. Thank you.
So let's jump into this. I feel like nudges and behavioral economics, it's so hot right now. Like, there have been a lot of trials. There was just a couple out on, like, one was on polypharmacy using behavioral economics. Another one was on decreasing low-value care that was published also in, I think, JAMA IM. Before we talk about what you did in this study, maybe, Scott, I'm going to turn to you. Can you give me a reminder what a nudge is?
Sure. I think it's...
Oh, Alex just hit me.
Maybe that was an elbow.
That was not a nudge.
Sorry. Go ahead, Scott.
Hey.
It's getting real here.
If you don't like this response, you can't hit me. So that's good. I think it's good to place nudges in context. So there are a lot of policy levers at the disposal of any party that's trying to influence behaviors or outcomes. At one end of the spectrum, you can provide decision makers with information. That doesn't work very well in most contexts. At the other end of the spectrum is you can totally remove certain options. So you could think about, formularies at the hospitals we all practice on. I can't prescribe certain drugs. I'm just not allowed to. And that works really well. But it can be seen as constraining the autonomy of the decision makers. Behavioral economics sort of operates in the middle of those two poles and can be defined as any feature of the environment in which a choice is being made, or in which, or the way a choice is being framed, that can foreseeably influence the probability that a specific choice is the one that's made without removing any choices or materially changing the incentives to make one choice or another.
So if you're like a Starbucks and you have a small and a large coffee, you want to get more people to order the large coffee, you add a super large coffee. So you haven't restrained or constrained choice. You've just driven more people to buy the large coffee because it's kind of the middle option.
That's exactly right. And that would be what we would call like a expanded choice set nudge. And in fact, that's a nudge that's kind of near and dear to Kate's and my heart, since it was the topic of her master's thesis many moons ago.
Oh, yeah? Kate, can I...
What's
like
the healthcare equivalent to the Starbucks coffee?
Yeah.
I invited patients with end-stage renal disease to complete a short advanced directive, a medium-length advanced directive with some more options, and the really full, lengthy living will advanced directive.
With all the legalese.
The Ayn Rand version.
And more patients were willing to complete advanced directive and picked the middle one.
That's good.
Yeah, and these multiple choice set nudges and some of the nudges we're going to talk about today they're nudges that can often be very useful, but they're not kind of like the granddaddy nudge, if you will. The granddaddy nudge is the one we talked about on our last podcast with you, where you change the default option. The events or conditions that'll be set into place unless some active choice to the contrary is chosen. So that's by far the best studied. It works in almost every context in which it's been studied, et cetera. What we're going to be talking about today are more nuanced nudges that for which the evidence base can be considered to still be evolving.
Yeah, so I always remember back to your advanced directive nudge study where you changed what the default is for the advanced directive, right? Yep. So it was already X'd out like comfort care or DNR, or you got one that was
selected.
It was selected.
Comfort care was selected.
Comfort care, you either got one that was selected, and if you didn't want it, you had to cross it out, or like full treatment, full code was selected, and if you didn't want it, you cross it out. And what I remember from that, correct me if I'm wrong, Scott, is that if you got that comfort-focused one, like 80% of people wanted the comfort care focused one. But if you got the other one, it was like much like it depended which one your preferences, your end of life preferences depended on which advanced directive you got. Did that sound right? Am I summarizing that correct?
Yeah, you're summarizing it perfectly. It was actually two separate randomized trials that had the same general conclusion, that you could meaningfully change the proportion of people who made choices about their future care in comfort-oriented or life-extending-oriented directions by just flipping the way the choices were framed. And those effects were true even though we told people that we were doing this at the end.
And then a chance to change it, and nobody changed it.
Yeah,
well, not nobody,
changed.
but fewer.
Yeah, almost no one.
And so the key insight there was, I think, which is relevant here too, is sometimes people are making choices about things that they don't have like pre-existing, really well-ordered preferences about, that like they might have preferences in sort of a gestalt sense, but they haven't like given them a lot of thought. And those are areas that are kind of ripe for nudging.
Yeah. And some of this might just be like it takes effort to overcome that default, right? And so this morning I came in and there was coffee grounds that were hot, but there was no coffee left. And so what I did is I made some more coffee grounds. I added them on top of the existing grounds. And then I poured more water in the coffee maker. And then I told Eric what I did. And so it was my laziness that did that. And then Eric came back with a norming statement.
Dear Jerry Powell listeners, I'm searching for a new co-host for the Jerry Powell podcast.
This is worse than anything he's ever heard of. He was like dying inside because I had reused the coffee grounds. So my question is norming probably the most common nudge in our society, inside or outside of healthcare? Would you guess?
I mean, I don't even know what to call that, Alex. That's just norming or absurd.
It could be on the coffee.
The norming, this is what I should have done. When Alex came in, I should have used the nudge. I could have said, most people who make coffee do not reuse coffee grounds. Yes, so I'm nudging Alex using social norms to not do something that he should never do.
Yeah.
I'm not constraining choice, right? I am just nudging him.
Does your wife know about this, Alex?
She will when she hears this podcast.
I just want to highlight the last time we had Kate and Scott on. I highly encourage you. We did another nudging trial where the default was for default palliative care consultations for high-risk patients, and it significantly increased individuals who were receiving palliative care. And again, we can go into kind of what they found on the topic. Highly encourage you to jump in and listen. But I got to ask, so you're doing these nudging trials.
Wait, can I ask about nudging before you?
Go ahead.
Okay. Because my wife yesterday, she said, what are you doing? I said, I'm doing a podcast about nudges in the ICU for critically ill patients. And she said, is that the accepted word now? Do we say nudges? Is that okay?
Or
and it's
behavioral interventions? Or
I mean, there are all these terms.
Yeah, I think so. I mean, Cass Sunstein and Dick Thaler wrote a book entitled Nudge, right? New York Times bestseller for many moons, to reuse the statement I used before. I also think it's useful in the sense that it is differentiated from sludge. So you guys referred to sort of the work involved to overcome the default or whatever it is, right? That is what we call kind of like sludge. Like if you make it hard to make a specific choice, that's sludge. That's not a nudge. And so the fact that they end in the same sort of
okay. Well, like a default makes it a little bit harder, right? You have to expand a little bit more energy to make that change. Why is that not sludge?
Because a default has to be set it oftentimes has to be set in one direction or the other. So it's an apples to apples comparison of the effort. There's always some effort involved. By contrast, you could make it so that like the fact that a default is set is totally hidden, and you've got to click through 27 different prompts in the EHR to overcome it. That would be sludge.
Oh, okay. All right. This is good.
All right. Hold on to that because I got questions once we talk about the nudges that you did in this trial. But Kate, I'm going to turn to you. Why did you decide to do this trial at all?
This particular trial, the Panda ICU trial, I'd say the overarching objective was to improve adherence to really best practice guideline recommended communication with seriously ill patients in the ICU. By that, I mean those at high risk of death in the ICU or in the hospital or severe functional morbidity thereafter. And it's been pretty well written about for a long time that that's the right thing to do, but we don't systematically or routinely do it. And so how do we, as Scott said, sort of use our levers we don't think clinicians don't do it because they don't want to, or they don't think it's the right thing to do, but perhaps they just need it reminded, put in their face, this is the right context, and sort of give them that support and facilitation.
So what did you do in this study?
What did we do? We tested 2 different nudges individually, and then we combined them. So there were 4 study arms, one in which we had no nudges, and then one for each individual nudge and one combined. And the nudges were focused on 2 areas of communication. One, prognostication, in which we asked the clinicians, this was based on something called a focusing effect, whereby, ICU clinicians in particular have a lot of data coming at them and maybe tend to focus on the blood pressure and the heart rate. And we simply wanted to focus them on prognostication and specifically death and functional morbidity, as I mentioned. And so we simply asked them to do that, prognosticate 6 months for mortality, and if alive, what they thought the functional status would be. We didn't make them do anything with that information, just document it. We didn't make them communicate it, but we focused them on it, which makes them more likely to then utilize that information. And then the second nudge was based on multiple recommendations from professional societies that for these types of patients, we should offer the option of care focused solely on comfort on the same footing as care focused on longevity. So continuing life support and comfort focused care are very reasonable options for patients with these potential outcomes, but we don't tend to offer care focused on comfort until we think there's literally nothing at all left to do to extend this person's life. And we sort of don't talk to people about them in the same way. And so multiple professional societies have recommended this. So we leveraged a nudge that is called accountable justification, has been used in multiple other contexts. But the idea here is simply that, clinicians are trained to make decisions backed by reason. And so we simply asked clinicians, have you offered this patient and or their family the option of care focused on comfort? If not, why not? And that's key. The justification is a key part of it in that it's a normal part of their decision making to have reasoning. And we're simply asking them to be accountable for said reasoning, just like they would document why they did or didn't give an antibiotic for a pneumonia.
So I can imagine for the accountable part, somebody would actually have to see it. Like it just doesn't go into the ether if you put that reasoning out there.
Right. This was, these were EHR documents in the patient's chart built within the Atrium Health's electronic health record where they document other things. Mm-hmm.
And Jaspal, you practice in Atrium Health, right?
Right.
What is that? What did this look like actually for the ICU physician? Was this like a researcher coming in and asking these questions? It sounds like no, it was built into the EHR.
It's just depending on when you access that EHR. So basically, the prognostication is happening in the background, and like once a day or so, this thing would prop up. This little button would pop up and sort of ask you to prompt through, and just ask you a couple of simple questions, and you had to respond in the EHR. And basically, that was the extent of the intervention. It wasn't sludge, I think, like the way Scott described it, right? It was fairly straightforward, and it wasn't very complex. And that's where the beauty of this intervention was.
I got to ask another question, though, because I work in a healthcare system where when I open up the chart, a box comes up. I have no idea what it says. I just click OK right away.
I do. I've never read that box. I have no idea what it says.
Right? No idea what it says.
So is there a sludge effect from having like one more pop up? You know what I mean?
Or fatigue, pop-up fatigue. Like there's so
whatever
many
you want to call
pop-ups.
No, absolutely. And especially that requires a lot of education. But I think the fundamental premise here, and something I think is sometimes, for your audience is probably innate, but for me who's practicing in North Carolina, and not just at the main resourced hospital, but also at the smaller hospitals, the community hospitals, we looked at this across the geography. A lot of our clinicians want to have these conversations, but they sometimes feel they don't have permission. They don't have the space. They don't have the time. They don't have the expertise. And so you end up with this really complex phenomenon on a very complex problem of like, people want to do well. They don't know how to approach it. And so they end up not doing any of it. Right. And so it kind of brings it up into your face to have these discussions. And yes, we did a lot of prep work because, as you know, alert fatigue, coding, billing fatigue, error. I mean, there's all these sort of pop-ups that come up. And we did think carefully about that, which took a lot more complexity to think through this. But, we managed to work it through, and people got used to it. And throughout the duration of the trial. But what's really cool is that we got insight not just from the main hubs of centers, the tertiary ICUs like where I work, tertiary quaternary centers, but also the community centers that are 30, 40, 50 miles away from the main centers. And I think that's where I think has got really interesting.
I just add one more thing on that score, because I think this often comes up. I don't want any more alerts. Get rid of all the alerts. I already get too many. Agreed. We all get too many. Yeah. But the solution to that problem isn't to not test hypothesis-driven novel alerts that are foreseeably designed to improve patient outcomes. The answer to that problem is to not allow prompts or alerts that haven't undergone such testing.
Like the one me and Alex just clicked, but we have no idea
we don't know what it says.
Yeah. We commonly, at the start of these EHR trials, have conversations with operations and informatics folks who tell us they won't work because they have an average of 10% response rate to their alerts. And we're like, oh, they'll work because we're going to design them differently with science in mind and evidence. And we have much higher adherence and response rates. In fact, in this trial, I was very proud of our adherence rate. As Jaspal said, you've got 2 interventions in the middle of ICU rounds. Maximum were 4 questions if you had both combined, but either way, you're interrupted, you're doing something, and your patients are sick, very busy or attending to multiple things at once. And we had 75% overall adherence, which is phenomenal in an implementation sense. But if you look at those who were just the way our eligibility criterion worked, if you were eligible for at least 24 hours, because if you were extubated or left the ICU shortly after you became eligible, the prompts would stop, of course. We had almost over 90% adherence. So people did attend to this. It was not required.
And adherence is you completed with the prompt.
Mm-hmm.
You responded to the prompt. So you put in your prognosis statement, or if you got the alternative, yes, I did it, or no, here's my reason why I didn't do it.
Correct. And I would agree with Scott. I don't think there's an example of greater than 90% or 75% adherence in the typical alert that kind of gets just turned on by a health system for, all sorts of reasons.
So it seems like you had buy-in. Yeah.
Mm-hmm.
Mm-hmm. Great.
And who are the patients included in this study?
These were patients with a pre-existing, at least in the last 12-month look back, of a chronic serious illness. Pretty much every organ system, we really tried to be very broad, and we're receiving mechanical ventilation for at least 48 hours continuously, and adults.
Okay.
So pretty broad criteria, but also very, very sick patients. Had in our preliminary estimation, we saw about a 35% hospital mortality rate among a historical cohort that met those criteria. And indeed, that's what we saw in the trial as well.
35%. So about a little over a third died
in the hospital, and more than half died by 6 months.
Okay. So very high risk group.
Mm-hmm.
And pretty low bar intervention. Like this intervention sounds like it's scalable, easy to plug into a healthcare system. Your primary outcome was similar to the primary outcome the last time you joined us on the palliative care, the Geriatrics podcast, which was on default palliative care length of stay.
I thought we agreed not before.
Yeah, I thought we were going to refer people to the past podcast.
If you want, you should have nudged me before we started not to talk about this.
Wait, can we talk about it quickly though? Because it's complicated and we don't want to overcomplicate it for our listeners.
But so the actual
we want to get the results.
Why did you choose length of stay as your primary outcome here?
Hospital length of stay.
Hospital length
of stay.
This is a palliative care study. Ultimately, like it's not a study of palliative care clinicians per se, but it's a study of like the construct of providing high quality palliative care. And at the time we launched the study, the prevailing business case for palliative care had to do with the premise that its provision in a high quality way could reduce length of stay. And as such, it would be important to conceivably all stakeholders, like patients want to get out of the hospital sooner, their family members want them to get out of the hospital sooner, the hospital CEO wants them to get out of the hospital sooner so they can admit a new patient, the clinicians want them to get out of the hospital sooner for myriad reasons. So it aligns in the sense that it's important to all stakeholders. It had a prevailing conceptual foundation in the sense that whether or not you believe the data that existed at the time that it might reduce length of stay, like that was part of the way it was sold. And so that's why we chose it. And as I think Kate and I both articulated in all the ways we possibly could. We have sworn on our graves that we will never, ever design a palliative care study with length of stay as the primary outcome ever again.
What, and why?
There's just too many competing factors, right? Like the ability of someone to leave the hospital for social needs reasons, all the different things that are completely outside the domains of palliative care that influence length of stay and hence really degrade the signal to noise ratio of that outcome measure. And then finally, that there's actually no agreed upon straightforward method for analyzing length of stay data that doesn't rely on certain untestable assumptions.
Yeah, and just briefly to ward off those of you who've read the article and may have concerns that death was included as one of the longest lengths of stay in the primary analysis, and you might think, oh boy, that's like punishing death. Like it's as if they had a huge long length of stay. But then our authors today did 1 billion different sensitivity analyses that basically showed no matter how you slice it, the results were the same, where you counted death as like a really short length of stay or whatever.
And we dived deep into that on our last podcast. I don't feel like we got
to the other podcast. Yeah.
and only 900 million of those billion sensitivity analyses were requested by the handling editor.
Okay, let's jump into what did you find? Did it work?
Well, are we talking about the primary outcome or?
Yeah, well, the primary outcome, length of stay.
Alex just stole the thunder. No matter how we analyze length of stay, these nudges combined or individually did not change hospital length of stay. However, we saw significant increases in hospice enrollment with the accountable justification nudge, the have you offered care focused on comfort nudge, both unto itself and when combined with prognostication. And we saw earlier comfort care orders. So those without an increase in the proportion who we had comfort care orders. And I think that's important. And without an increase in hospital mortality. Because what it really says to us are that these nudges identified for clinicians, patients for who were likely to die in hospital and likely to ultimately receive comfort-focused care at some point. They just received it earlier, arguing potentially, less time receiving life-supportive therapies that were non-beneficial and maybe not wanted, as identified perhaps during a conversation. So those were the main takeaways. The prognostication nudge alone was not effective. It had no signal in any primary or secondary outcomes. And then when combined with the treatment alternative, the idea of there's another way to do this, there was some signal in those outcomes. So I think that was, probably the active ingredient in the combined set of nudges as well was the accountable justification.
So let me get this straight. So just having people think about or focus on prognosis, prognostication didn't really change any of these outcomes, primary or secondary, 18 secondary outcomes, right? You looked at.
It did not. Let me just add that the premise for that particular intervention, interestingly, was a simulation study done by colleagues at Johns Hopkins, I think led by Alison Turnbull, where she showed a signal for willingness of clinicians who were told to focus on prognosis in a hypothetical study were then more willing to offer the alternative comfort-focused care just by thinking about prognosis. She followed that up with another study to test that in a more real environment, and it was null. That obviously was published well into our trial. So we sort of wonder if perhaps the premise of the focusing effect and the prognostication in the end, when put to the real test in another study, was not quite as powerful as we had hoped.
Yeah, it feels like it has face validity though. Like when I'm in these pre-family meetings where we're sitting down, actually having people think about prognosis kind of helps them think about
Yeah.
thoughts and their recommendations, whether it be like oncologists, or
Right.
primary team members.
Right. Though we should note that's a different setting. That's before a family meeting where you're probably going to have a goals of care discussion, not in
Versus just
daily
the
rounds. Yeah.
That's a good point.
But it's important that what we're not able to say, Alex and Eric, is it's possible that these interventions, while not exerting effects on things that are easily measured in an EHR, which is what we do in pragmatic trials, could have foreseeably nonetheless changed the types of communication offered in family meetings and even more kind of rote day-to-day conversations on rounds with family members who are in attendance. So we don't have any way of getting at that, but it is a plausible premise.
So I got to ask about that. So the positive findings you had around the alternative type of care, the comfort-focused care, it was 2 out of the 18 different secondary analyses. And I think this came up in the editorial. How much weight should I put into that, given that, statistically, if you look at 20 different outcomes, maybe one of them will be positive.
By chance alone.
By chance alone.
Yeah, I think it's a fair criticism. My two sort of off the cuff thoughts are pretty plausible mechanism for how we got there. It's not like we have to work that hard to put together how A to B led to C for those two particular outcomes for these interventions. I think that matters a lot here. The other one is simply that, these, as Scott just said, these pragmatic trials are trying to tell a whole story. And there is a struggle between sort of the traditional really limiting what you're looking at and being very, very narrow in these efficacy trials and this idea of I'm trying to understand an ecosystem, but reliant on existing data.
Yeah.
And trying to be able to explain the findings the best we can. And that, if you look into sort of how to think about pragmatic trials and answer to many, many different stakeholders, which they are intended to do, you really do need to look at a number of different things. Is there a world in which we can call some of these tertiary? Maybe we just start leveling them and we don't get so upset about how many secondaries. But I think it's a less interesting study if we were to just pick 3 secondary outcomes and there's this whole other slew of things we're all interested in understanding and we don't do it because, we're worried about that kind of criticism. But it's a fair criticism.
Scott,
if you have anything, statistically or otherwise to sort of respond to that kind of, thinking.
I do, but I don't know if Jaspal, you wanted to weigh in on this.
Yeah, I mean, I think the criticism's fair. And were we disappointed that length of stay didn't change? Well, maybe. But the bottom line is, I think for such a complex topic, to distill it to a behavioral intervention, I think to understand the environment of critical care in the area in which I work and the different hospitals and different centers, I think actually the idea of comfort-directed care improving in terms of the uptick in that, I think that's pretty powerful, especially in this region of the United States. Culturally, it's a little bit different than perhaps other areas where, palliative care is not ubiquitous. There's a shortage, there's a massive shortage. In fact, many of the centers that we studied this intervention in are places where you don't have intensivists, you have hospitalists, you have NPs and PAs rounding in the ICU. And for them, they may not be as comfortable seeking permission to engage with family. So these aren't things that we necessarily could do at a large trial on the outset when we designed this study, when we implemented this study, I should say, on my end. But looking backwards actually at it, I thought it made a huge cultural difference. And if these markers are secondary, sure, it's great that we analyzed all these, to what Kate said. But I think there's probably a powerful signal in there that actually is much more complex and nuanced, especially when we think about social justice, areas that are under-resourced particularly. I think we have to think about those populations a little bit. And I think, yes, the science gets diluted out in terms of the signal that we want to see, but I still think it's pretty powerful.
So do you believe, it sounds like you do believe that get the nudge of offering that physicians should offer comfort-focused treatment alternatives had this effect on both hospice utilization and comfort care orders?
I do believe that. And so as the site-based PI that was responsible for education in this space, right? It's amazing how many conversations I had to have with people like, what is this? Oh, you mean I can sort of act on this? Like, it was shocking to me at how many people hadn't occurred to them to actually, when the patient has clearly a prognostic challenge, that basically that clinicians were uncomfortable and all of a sudden became like, oh, okay, I get it now, what you're trying to do. And throughout the duration of the trial, which we didn't talk about the trial being interrupted with COVID and all the dynamics of all of that, right? That all of a sudden, the end of life discussions all of a sudden became somewhat normative in areas that were not. And I think that's an important aspect of the study, which I think was hard to capture because of all the factors in the study design.
Scott, any additional thoughts on that?
My first thought is just to thank Jaspal for that really like lucid and insightful explanation from eye level view on the ground.
Yeah,
I think it really adds a lot of color. The only other thing I was going to add, sort of in response to like this issue of the criticism, which I agree is valid from a statistical sense, but I think we need to think about like where the burden of proof is, or how high the burden of proof is here. The burden of proof would be really, really high if we're talking about what's often studied, which is hiring extra FTE, whether it's nurse-led navigators in the ICU or extra social workers, extra palliative care clinicians, all these things that cost a lot of money and have real opportunity costs associated with them. Or if we were talking about an intervention, no matter how much it cost, that had like real potential to harm. Neither of those things are true here, right? So we're talking about dirt cheap, readily scalable interventions that you'd have to be really creative to think about how they might harm someone. And in fact, and for sure, we didn't see any evidence of harm. It's in fact very important to point out that mortality didn't differ across the arms, length of stay wasn't shortened, but it also wasn't lengthened, like et cetera. So sure, would the scientists in us want to see a replication study that showed the same results in a different setting? 100%. Yeah. But if we don't get that study in the near future, health systems still have a choice to make. And, a little evidence in the right direction for conceptually compelling outcomes that, like have a clear mechanistic basis to them, I might be in favor.
Mm-hmm. Yeah, I really like the sort of public health angle here, both in terms of what you were saying with this low resource. It's, pretty easy to implement, as opposed to going back to Eric's analogy, like having a trained palliative care physician going in and asking them what they think about prognosis and making eye contact with them. You're a little bit different from an electronic prompt and a lot more expensive. And I also appreciate it from what Jaspal was talking about reaching community hospitals and critical care facilities. Like, one of the beauties of this study is just the population and the hospitals that were included and the potential generalizability of these findings outside of the sort of ivory tower academic centers, which are so often the subjects of the palliative care trials that we have people on and talk about. Are you going to ask the what's next, if you could do it again?
I just want to know, what do you do with this information? You have this trial. What do you do with it, Kate? Should we be implementing this? How should we be thinking about
Yeah. If I were running my own study at my own health system, I would be asking my ICU docs if we could implement the treatment alternative. Maybe it's not a prompt, maybe we don't want an alert. Maybe there's a smarter way to get it targeted to the ICU docs. But given the conversations, like to Jaspal's point, some of the operations and sort of the larger culture, we're talking about this stuff all the time in our ICU faculty meetings. Is we're underutilizing hospice. There aren't enough communication documentations. Where are these advanced care planning notes for these patients? And, here you go. You could, you could just simply remind us, and we would do it more often, it seems. So, yeah. But, that would mess up my ongoing trial. So that is one. If there's another health system taker, I do think, to Scott's point, it is It is off the shelf, easily replicable to institute. It is a low lift and a low lift for clinicians too. And it's the right thing to do clinically for patients and families. Like it doesn't have a lot of knocks.
Yeah. Jaspal, was it deleted from Matron Health, or is it still being used, the prompt?
Well, it got deleted after the study was finished, but I think we learned a lot about decision support, about decision analysis, about the idea of nudging and how to design interventions. I think it was just complex, right, to kind of continue the moving forward.
Yeah.
But I think that if you ask what's next, I think it provided tremendous insight as to how we go about sort of approaching very complex interventions at scale. When I mean scale, I don't mean just one hospital, one facility, but as a large organization. What is, back to our initial song, what is, ICU rounding, right? ICU rounding right now is so heavily nuanced. Certain people, it depends on the attending, depends on the environment, depends on the hospital, at some point, it doesn't make any sense, right? There are certain things, to Scott's earlier point about decisions, that just need to be made. We're having the same conversations in parallel types of intervention in the ICU, called the ICU liberation or ventilator weaning or other aspects where some decisions just have to be taken away or have to be at least limited. Some decisions need to be potentially trimmed down in terms of options, in terms of what clinicians choose. And it can't just wait for the super specialist, in this case, the palliative care specialist, to come in, because that's a Monday through Friday at the secondary tertiary center, but not at a primary center of ICU care, right? Yeah. That's not an option. Even then, there's workforce issues, there's subjectivity, there's biases that are all throughout, right, that color that interaction. So then you step back and how you design an ICU and how do you deliver care effectively across an entire geography at the minimum standard, right, has to somehow be, I think nudging has to almost be engineered into the decision-making process, which is, again, if I were to imagine how ICU is rounding, I would probably design it very differently, right? And I would actually start putting things like nudges on this issue, nudges on mechanical ventilation decisions for liberation, for example. There are certain things that could potentially relieve the clinician from all those decisions that they're making and move towards what we call a standard that we define and that society's working on defining. So that's how I look at it, is I think, we didn't continue this intervention, but to Kate's point, this may not be the perfect intervention. There may be other things to think through this space. But I think this triggered a lot in me to think about how we can do better, especially since we carried this through the COVID pandemic, right? And you can imagine the complexities at a rapid fire pace, end-of-life discussions, mechanical ventilations, ECMO questions, huge survivability implications, right? Having to make clinicians put them in very uncomfortable situations at a rapid pace, at a massive onslaught of acuity. And so it had to really think through, if we had to redo things, should we prepare for that situation?
Yeah. And I guess that leads me to the last question for you, Scott, is, so I love what Jaspal was saying, is like introducing these nudges, but it also feels like the system is currently designed with these nudges. They're just nudges to do very aggressive things to people at the end of life.
The default pathway.
The default pathway is to keep people in the ICU, is to keep them full code. It's the default. Nudges are built into the system. And is it to think about, are there alternative nudges that may also improve quality of care? Thoughts on that?
I'm not sure my thoughts will reveal any more than your smart question revealed, which is that we ought to be, in a normative sense, defining nudges mindfully rather than our tradition of implementing nudges unknowingly or haphazardly, right? There's no option to not nudge in many, many contexts. And as you correctly stated, a lot of the prevailing nudges are in one direction. So well thought out, well designed nudges that might move in an opposite direction could be value added. And then, it's hard to get through a podcast on these at the intersection of palliative care and ICU medicine without thinking about Randy Curtis. And one of the many, many wise things that Randy taught so many was that oftentimes you learn more from the interventions that quote unquote don't work than the ones that do. And we're running lots of trials now that I think will be more effective in this general space.
So should we be expecting more behavioral economics studies? Kate, sounds like you're working on one.
Yeah, you know it. I agree. I think these aren't just one and done. We're really building and learning and getting smarter about implementation and honestly getting smarter about understanding the culture and context in a larger sense, as Jaspal described, and trying to get in to be more eyes and boots on the ground during the studies in the centers, learning as it's happening instead of only relying on our hypotheses. And I think that'll be also a really big difference in future studies.
I love that. I can imagine a world where we're thinking about behavioral nudges differently than our current defaults, which takes us to the song, Alex.
Imagine all the people living life in peace. You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us and the world will be as one.
Kate, Jaspal, Scott, thank you for joining us on this Jerry Powell podcast.
Thank you for having me.
Yeah, and Alex, when I'm in San Francisco for ATS this year, I'm taking you to Blue Bottle, show you what some real coffee tastes like.
Scott, I got some better coffee places to try. Andy Town here. Oh, you got to talk to me.
Yeah.
And thank you to all of our listeners for your continued support. Most of our listeners have rated us 5 out of 5 on the favorite podcasting app. Here's the nudge.
Norming.
Think about rating Jerry Powell Podcast on your favorite podcasting app. And we'd like to send a special thank you to all of the donors who've donated more than $250, including
Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordofsky, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, and Paul Amatelli.
Thank you very much for your support.